Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and medical director of infectious diseases and immunizations at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic and increasingly about other infectious diseases participating in outbreaks around the state and the world. This is the first week of October. Happy pseudo fall to everyone. Hopefully you all got some rain earlier this week. Some good questions this week as always, sort of returning to a focus on vaccines and COVID and flu vaccines specifically. The first one is a very frequent question, and it is, what is considered up to date for COVID-19 vaccines for children? Specifically, what are the recommendations per age group? And even additionally to that, what is the impact of the newly released bivalent vaccines released by Moderna and Pfizer? So the important question is certainly it's been somewhat confusing lately with a lot of products on the market. For a rapid reference to print out and keep in your practice environment, I urge you to search COVID-19 vaccine schedule for children, and typically the first hit that'll come up is from the CDC, and it's a PDF, which is COVID-19 immunization schedule for persons 6 months of age and older. So that's sort of a relatively easy reference. And that PDF also includes the actual dose amounts in terms of the milliliters. It is somewhat different for the vaccines. But in general, and this is trying to summarize a confusing vaccine schedule, the monovalent vaccines, and this means the original ones that we're all familiar with from Moderna and Pfizer. So messenger RNA vaccines, monovalent, just sort of generally created now a while ago, are all approved by emergency use authorization for children ages 6 months and up for the primary series. What does that mean? That means for most kids, the 2 doses spaced by 4 to 8 weeks. Again, why that range of timing? And that's based on the theoretic concern of potentially post-vaccine myocarditis. So the CDC has come through and said it's perfectly reasonable to space those first 2 primary doses by 8 weeks, which largely reduces the chance of a hyperimmune response, probably makes that second dose of primary vaccine much more tolerated. In the younger, so especially age 2 through 4, so 2 up to age 5, the vaccine series, and Pfizer especially, is a 3-dose series. So again, check the PDF, given which product your clinical area is using. Make sure to use the proper dosing there. But in general, monovalent vaccine, primary series, all kids 6 months through 18. For the booster, so booster dose given at least 5 months after completing that second dose of the primary series. And in general, the booster is still the monovalent vaccine, again, Moderna or Pfizer. However, for kids ages 12 years and up, the Pfizer bivalent vaccine, the new one, can also be administered. Stay tuned to the media because both Pfizer and Moderna have petitioned the FDA just in the last 2 weeks to get emergency use authorization to use that bivalent vaccine from each of them for booster doses in kids down to age 6 months, and certainly down to age 5. So for right now, though, if you only have the monovalent vaccine and cannot get, or honestly are concerned about trying to refrigerate and store the bivalent vaccine, then it is reasonable to continue with the regular strength monovalent vaccine, either Moderna or Pfizer. And at least for now, if you happen to have bivalent vaccine around, the Pfizer specifically can be used for ages 12 and up. So that is sort of a general overview of the recommendations, and it hopefully can provide a little bit of clarity to what is out there. The Novavax vaccine, I took a question about that at a symposium recently. That is a great vaccine. Remember, that's the sort of subparticle vaccine. It's a more traditional approach to vaccination and maybe more acceptable to those who are vaccine hesitant for the so-called new mRNA vaccine technology. Unfortunately, the Novavax is still only approved, or emergency use approved, for ages 18 and up. And it does not appear there's any strong push to lower that age limit at this time. Too bad, because it actually does have some pretty decent efficacy, not recently tested against the recent Omicron variants, but it's a good vaccine, just not really accessible to us in pediatrics. Part of the question in terms of the vaccine schedule also asks about resources to provide to parents, and the AAP on its website and also the CDC both maintain really good web pages and resources written in accessible language for parents and patients as well. So I urge you to sort of play on the AAP website, find those documents, and either print them out or have the link which one can hand to the parents when they ask that question. Sort of related to that question, will COVID-19 boosters be provided annually? Boy, I wish I could predict the future. I think that's the direction we're going. Certainly that the bivalent vaccines were rapidly created, not in a cult or a non-scientific way, but using the mRNA vaccine platform, it is very easy to actually type any new variants out there and insert the important spike protein components in a new vaccine. So, the science is solid, and it's just a matter of if something new emerges, like a new variant that is showing vaccine escape tendencies from the current circulating vaccines, then yes, I anticipate we'll be seeing a booster every year, very much like we currently administer the flu vaccines every year. It really depends on how nimble the SARS coronavirus 2 continues to show itself. Certainly influenza is quite nimble. It potentially can change every year, every season, sometimes several times in the season. We've experienced SARS coronavirus 2 and COVID-19 doing that as well. Also because globally we've been unable to snap the pandemic and the virus itself has absolutely entered its endemic phase, I think it is likely that we'll see, if not every year, but certainly potentially every couple years, or maybe annually, we'll see. But we will see like a new booster coming out. As it now stands, the bivalent booster is out. It's definitely a good idea. For those of you who are ready for a booster and have not yet experienced recent COVID-19 like yours truly, it's time to go ahead and get that bivalent booster in. Just get her done so you can avoid this nice chronic cough from COVID-19. Fabulous. Another question, is it okay if I get Pfizer when I originally got Moderna? Yes, absolutely. The vaccine types are interchangeable. In fact, there are some who actually advocate for mixing your mRNA vaccine types to sort of create a heterologous vaccine boost phenomenon, which basically means, although the vaccines are identical in their technology, they harness slightly different components of the spike protein active binding site. So if one were to have had, for example, a Moderna vaccine series for your primaries, and maybe got a Moderna booster or a Pfizer booster, it is quite reasonable to pursue a Pfizer bivalent vaccine booster, and vice versa. Pfizer for your primary, then do the Moderna. They're honestly interchangeable. Is it a good idea? There's been no science comparing, all same vaccine to heterologous vaccine, but the scientific suggestion is that there is an increased booster phenomenon if you can mix things up. Certainly, those who have had a significant vaccine take. So, for example, if you still remember clearly your last Moderna vaccine because your arm fell off and you were sick as a dog for 24 hours, etc., then it might be reasonable to change up and go for a Pfizer vaccine, which will still provide excellent seroprotection, but maybe mitigate somewhat the post-vaccine reactions that you had. So, just a suggestion, again, no evidence to confirm that. And if you do that and experience otherwise, do let us know, because a lot of what we're currently at in terms of vaccine recommendations is based on increasing amounts of anecdotal evidence. The observational studies, not that they've stopped, but they're far less prominent. And unfortunately, the COVID-19 pandemic, in terms of the manuscripts, the journals, the media for sure, has really been supplanted by other stuff out there, to wit, measles, polio, monkeypox, influenza, etc., and so forth. The new subvariant, so SARS coronavirus 2 subvariant BA.2.75.2, is this going to be a factor this coming winter wave? What is this variant? So it is closely related to prior BA2 variant, which has already circulated through the United States and Arizona. And to remind you, we're currently experiencing primary cases with the Omicron BA5 and BA4. So the BA2.75.2 is out there. There are sporadic cases demonstrated throughout the world, throughout the United States, and in Arizona. But it is currently felt to be of fairly limited clinical significance, meaning that most of us still have some residual seroprotection against it, that it is not as infectious and not as virulent as the BA5 and BA4 are currently felt to be. And so it's sort of like, okay, yay, new edition, who really cares? But again, trying to predict the future may be that those few who are not yet either infected or experienced with COVID-19 in the Omicron wave, and also who are or under immunized, it may be that they will experience infection of the BA2.75.2. But I don't anticipate that that's going to make any huge difference in terms of any winter surge. Yes, there will likely be a winter surge just due to normal viral dynamics. In the rest of the country, remember, it's getting something called cold, like temperatures below 50 apparently. And so that will drive people indoors into superheated dry air, close contact, and it'll drive their interactions with each other. Arizona is a little bit different, and our more dangerous season are the hot months when we are indoors under air conditioning being close together, but yet still dry winter air, which we also still will get, that increases the presence of virus at nasal and respiratory epithelial cells and the ability for those to be transmitted by sneezing, coughing, hacking, etc. and so forth. So I do anticipate that in Arizona, as in the rest of the country, we will have something of a winter surge. No one, in terms of the predictive modeling, expects this to be anywhere near as severe as the last several winters that we have experienced. So will there be more cases? Yeah, probably. But we're still having a low to moderate amount of spread right now as I speak. So I don't anticipate it's going to have any huge clinical significance as things now stand. Yes, the virus could mutate horribly between now and, say, November. Hopefully not, but it could. It's certainly shown itself to be that nimble, and I could be talking a different tune in 2 weeks when the next time I'm recording this. But at least for right now, yeah, we may be seeing the subvariant 2.75.2, but without a significant major change. All right, sort of moving from COVID-19 to the flu, every indication, every prediction, every scientifically supported editorial and paper is predicting that this is going to be a horrible year for influenza. And there is some validity to that based on what Australia and New Zealand experience. And we typically look to that part of the world and those specific two countries to drive our anticipation of what flu will look like in our winter season. So both Australia and New Zealand are reporting not just a real flu season, but also higher virulence with the flu. And so, based on what their flu clades and serotypes are, current quadrivalent vaccines here in the United States, already accessible. I got mine 2 days ago. Good idea to get those ourselves, and good idea to start vaccinating our pediatric patients in the various practice settings starting right now. The question specifically asks, are 2 doses of flu vaccines recommended for children under 10 this flu season? So there's been no change in the typical recommendation for influenza vaccines in kids, even with the anticipation that this flu season will be a worse one than elsewhere in other times. So the 2 doses of flu vaccine are indicated for those children, certainly under age 6 and maybe even under age 10, who so far have only received 1 dose of flu vaccine per season ever, or have never been flu vaccinated. So the easy way to remember this is whatever kid comes in the door and needs a flu vaccine, if they so far have not received a 2-dose vaccine year, then they need to get that. And that's, I think, probably the easiest way to think about it. So even if, for example, a patient new to the practice or coming in the door of wherever you are, vaccine center, urgent care, emergency department, hospital, who previously came from another state and only got 1 dose of vaccine per year, they need a 2-dose year to actually get their immunity primed, boosted, and ready to go. But all other kids, so everyone else, even under age 6, under age 10, etc., who has already received at least 1 year of getting 2 flu vaccines, they're good. Just 1 vaccine this year and they're good to go. This year, the live attenuated intranasal vaccine has re-emerged with approval, but keep in mind that those patients who have chronic lung disease, who have fairly unstable asthma, and any child living with asthma who's on a daily control or medication is probably not a good candidate to get the live attenuated intranasal vaccine because it can and does still trigger an asthma exacerbation or at least some degree of reactive airway component in those kids who are susceptible to such. Given that the injected vaccine, quadrivalent vaccines, are so well tolerated and so effective, it's really, I think, appropriate to consider the live attenuated just for those kids who truly are needle averse, and we all know who they are, and can tolerate the live attenuated. So just so you know, so far this year, both types of vaccines, injected and intranasal, are approved, are available, and they're quadrivalent, so getting 2 types of flu A and 2 types of flu B. It certainly seems like a good idea now that it is October to start that vaccine administration if you haven't even already. So those are the questions to date. In terms of sort of general outlook for infectious diseases and pediatrics, thankfully nothing new to report on monkeypox. That outbreak largely seems to be not gone, and it will not be gone, but to be diminishing. And we continue to have just a handful of pediatric cases reported around the country. No pediatric cases that I am personally aware of in my practice area and in the state. Although they may be out there, and again, HIPAA is a very good thing to protect that information. But in general, monkeypox is still primarily not a disease that we're needing to be worried about, except for the worried well who come in with, a child with a rash of a different persuasion, especially the Coxsackie viruses, and we are seeing a fair amount of hand, foot, and mouth syndrome out there. Those kids with herpetic type lesions, whether it's varicella, heavens forbid, primary chickenpox, meaning under-immunized, and or primary cutaneous herpes, even herpeticum, which is another definite sort of mimicker, I guess is the proper English, a mimic of monkeypox. So monkeypox still out there, vaccines still available for those who are exposed to a caretaker with active or probable monkeypox, and increasingly there is enough of the Jynneos monkeypox vaccine available to start to immunize healthcare workers who may be front lines to assess patients with suspect monkeypox. So best way to get in touch with the updates of vaccine availability is to listen to notices from your local county health officer and follow their directions, because they're getting their directions through Arizona Department of Health Services and also through the CDC. So that's monkeypox. Measles continues to be of grave concern in Zimbabwe. So 40,000 or so pediatric cases, over 750 deaths reported in Zimbabwe from measles. Keep in mind that Zimbabwe is just a few plane rides away from United States territory. So it is possible, in fact, even likely, that we will have imported measles in this country and even in this state. So if you have not yet refreshed your memory on what a measles morbilliform rash and progression looks like, I encourage you to do so. Ample opportunity to search pictures online for those. And keep in mind also the 3 C's of measles, that being cough, coryza, conjunctivitis. The cough is it's called a brassy cough. Just think of the worst smoker's cough you've ever heard, sitting in an airplane right next to you, and you're like, oh my goodness. And that's the cough of measles, although it starts off, of course, as they all do, as a dry, non-productive cough. The coryza is very sort of not clear nasal discharge, but a pretty snotty, goopusy, mucusy nasal discharge, which is quite prominent. And then the conjunctivitis is the entire conjunctiva, not the classic Kawasaki's disease with limbic sparing or that sort of ring around the iris, but the entire conjunctiva, sometimes actually with some clear seepage from the conjunctiva itself. So those are the 3 C's, and if you have a patient with that history who also comes to you with a descending morbilliform flat macular rash, consider measles, especially in those kids who are unimmunized or under-immunized. So that's for measles. Polio, oh my goodness, yeah, that situation in the state of New York and now several counties, and unfortunately the city of New York, continues to evolve. No additional paralytic polio cases reported, at least not nationally, but the continued anticipation is based on wastewater sampling that there are now very likely hundreds, maybe even thousands of subclinical polio cases in those parts of the state of New York where they have lower vaccine coverage. So Arizona thankfully still enjoys a fairly high vaccine coverage for poliovirus. 93-94% is the average for the state of Arizona, although you may live in a practice area that includes typically, especially a school district that does not require polio vaccination for entrance into kindergarten or into the older grades. So if you are one of those heroes who is working and practicing that area, do keep in mind that there is polio out there and there is a chance that it will come this way. Still looking for that. The acute hepatitis of unknown etiology related to adeno-associated virus 2 and maybe adenovirus or some other triggers still out there. Sporadic cases that come to attention. Typically, that's the child with 3 days of fevers and both respiratory and gastrointestinal symptomatology. So cough, tachypnea, diarrhea, and emesis for 3 days or so, and then comes to clinical attention due to perhaps scleral icterus or emerging jaundice. That is the child who needs a full liver panel, an assessment of liver function, and discussion with infectious disease or hepatology, and potentially transfer to one of the clinical sites in the state that can handle such patients. So they're out there. We just, the last 2 weeks, had one suspect patient that is being assessed as we speak, and I anticipate we'll still have another couple individual suspect cases as we go forward. Other than that, we continue to see lots of respiratory disease related to our dear friend, not rhino/enterovirus. Again, that is likely an enterovirus, although it could be rhinovirus C. Both of those are detected by the PCR primers on our typical respiratory PCR panel in both the adult and the pediatric world, causing a whole host of respiratory illnesses, triggering our asthmatics into a severe exacerbation, causing respiratory failure requiring oxygen, bronchodilators, and sometimes steroids, even in otherwise previously healthy infants, children, and teenagers. So that's out there as well. Just ask any friendly emergency department physician, and they will attest, yep, it's out there. I'm seeing lots. Adenovirus, all other types, is out there as well. Certainly still seeing a sporadic RSV, starting to see influenza cases. So it's shaping up to be perhaps more of a normal winter for us, with the typical respiratory viruses starting to reestablish the old pattern. Of course, the proof is in the pudding, and in 4 months from now, when we're looking back at the surge over December, maybe, then we'll see if this actually holds true or not. So with that, thank you for listening to ID Talk. Arizona AAP members can submit questions for future episodes to covid@azaap.org. The Arizona AAP would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. In the meantime, and as always, hang in there, folks. We all appreciate you, appreciate each other. Take care of yourselves. Take a deep breath, and let's keep moving. Thanks, everyone.